So in the previous lectures, we've introduced the concept of cardiac rehabilitation as a multidisciplinary approach to patients with cardiac disease. And we introduced this case number 7 of an 82-year-old male who has a history of cardiovascular disease and then has surgery for an aortic valve replacement and a CABG. And then we spent the time since we introduced this case on talking about how exercise, if prescribed appropriately, could make a change over time. And that's our cardiovascular adaptations to exercise. So now let's go and think about how we actually prescribe this exercise. So phase 1 cardiac rehab is the time that's in the hospital, and now this portion is all on phase 2, which is really the exercise prescription intervention. So this would be out of the hospital. It's an outpatient portion of cardiac rehab that begins basically as soon as they're discharged would be the goal. They're starting phase 2. In order to implement phase 2 safely and effectively, patients will have an exercise test with EKG before. Most often it's recommended. This gets all kinds of important information as to their tolerance of exercise. It'll give you a rate pressure product if there was any ischemic issues at all, evidence of changes in EKG of kind of where is their heart rate range that's safe for an individual patient. It'll give you an idea of their functional capacity. So this exercise test is a really important beneficial piece. That hopefully by the end of this semester, if you aren't walking into this class with a good knowledge on exercise testing, you will feel confident in the type of information you would get. The goal in phase 2 is to get our patients to a 9 MET functional capacity. And again, MET stands for metabolic equivalent. So a 9 MET functional capacity is about 9 times greater metabolism than rest, because 1 MET is equal to your resting metabolic rate, or around 3.5 milliliters per kilogram per minute. A good cutoff to know is that a 5 MET capacity is largely accepted to be the threshold needed for safe return to most ADLs. So if somebody is below a 5 MET capacity, that's the top, that's their full tank that they have, they're going to be really impaired in terms of their independence and might not be independent. When someone is in phase 2 cardiac rehab, when they first initiate exercise, they will be getting continuous EKG monitoring and they'll have blood pressure monitoring before, during, and after exercise. How long somebody is monitored depends on their risk. So low risk patients, somewhere between 6 to 12 sessions will they be monitored. High risk patients, the number of sessions they're monitored might go up. But for all patients, the goal is to gradually wean off this continuous monitoring of the full screen and really teach our patients about the subjective signs and symptoms of different exercise intensities, using RPE effectively, being able to read their own body, being able to take their own heart rate so they can do self-monitoring. Because the ultimate goal is for these patients to become independent exercisers. Phase 3 is the maintenance program of cardiac rehab, where they should continue to have a healthy lifestyle that includes exercise for the long term. So the goal here is to improve functional capacity and exercise performance and enable a ability of independence with exercise. That's a really big piece, that patients feel safe to do exercise on their own. So the exercise prescription in phase 2 cardiac rehab would include aerobic exercise for about 3 to 5 days per week. Initially, the RPE is typically around 11 to 13, and then the goal would be to work up to an RPE of 14 to 16 as they progress through phase 2, as long as they're not having any signs they're not tolerating the exercise. 15 to 20 minutes of continuous exercise for the first month, gradually increasing with the goal being 40 minutes or longer once they reach that maintenance phase. The type, the most important type is the type of exercise they will actually do. Whatever is available to them, they have interest in, they like doing, or rather the thing they don't hate doing, is the most important type of exercise. If you could pick anything, rhythmic activity with large muscle groups is the easiest on the heart. Because the more muscle groups involved, the more you get a drop in total peripheral resistance, and it helps to limit some of the strain on the heart. You've got a much better skeletal muscle pump returning blood to the heart to assist in that venous return. That's a better exercise choice for somebody with a cardiac history. Outside of that, it's up to you. Treadmill, cycle ergometer, what works for the patient. So we've talked a bit about strength training all along, a lot in phase one, a lot in unit 1, where we were talking about how we make changes in skeletal muscle. Can you strength train somebody when they're in cardiac rehab? The general guide is included in your notes. After about 3 weeks of cardiac rehab, you could start strength training. If someone has had a myocardial infarction, that typically pushes it back to 5 weeks after the MI before you can start strength training. And then if it's a CABG, it's going to be 8 weeks. The recommendation when you're doing strength training in cardiac rehab phase 2 is to start with low resistance. So RPE of about 11 to 13. This next piece is a really good way to prescribe strength training so patients can be independent in progressing themselves. Their RPE during strength training should never exceed their RPE they rank themselves at during the endurance exercise. So in general, the endurance activity is going to be easier on the heart because you have the skeletal muscle pump assisting in venous return. You have a greater drop in total peripheral resistance. You have a less of an activation of your metaboreceptors because you're flushing out all the metabolites, which would result in less of a sympathetic response. So in general, the endurance activity is going to be slightly easier on the heart. So because of that, if you know that resistance training is going to be something of a greater stress than endurance, then you can use that as your ceiling for RPE. I really like that. I like things that are easy for patients to understand and easy to do. When you're doing your warm-up or you're doing your aerobic, if you rate your RP at an 11, when you go to do your strength training, don't ever go higher than that. And once your endurance, you get to 13, 14, and you're not having any signs of cardiac intolerance, and hopefully they're independent with that monitoring, then go for that with strength training. That's much easier than needing some kind of set number of weights they can do or percent of their max. I mean, that's great for us, and that's really great for progressive overload when you're designing a perfect exercise plan. But in the real world with real humans who need to go home and do the stuff on their own, these kind of things work really, really well. And in general, you progress really slowly. So if you're going to include resistance exercise in their training protocol, you would probably have that associated with some kind of a goal. And there might be strength goals independent of their cardiovascular health. We've kind of already hit that in Unit 1. Let's just talk specifically about what resistance training can do to the cardiovascular system. It's important to have our heads around what will change over time in our patients when they're doing resistance training, because if we're prescribing it, we want to know what we're doing. And it could be good or bad. You want to make sure it might be a goal setting, or it might be something you're watching out for, depending on kind of what type of patient. So let's look at the adaptations to resistance training. There's these great animal studies on this. The initial research on resistance training put so much focus on the skeletal muscle response, which makes sense because that's the primary goal. Hypertrophy, increased strength, this is why we're doing it. But there has to be an effect on the cardiovascular system if you're creating this, in some cases, greater strain on the heart than we're seeing in aerobic exercise. So these animal models gave us a lot of ability to really see what was going on in the cardiovascular system in ways that's not always safe for humans. So they were cannulating animals, and this is the little weightlifting station. So he's got his little metal plate here, and they could change the load that he has to stand up against. and he gets an electric stimulation that encourages him to stand. And I know some people don't like animal research, but that's just so cute. This little guy and his little bench press machine. Okay, so, or not bench, what am I talking about? Squatting machine. So anyway, what they did was they cannulated and they had the animal do resistance training. And they were able to get beat by beat recordings. And you can see there are 10 pressure peaks for 10 repetitions. And this is, by definition, ventricular overload, right? Every time there was a contraction, there was a spike in pressure as the muscle occluded the vessels and increased total peripheral resistance, and the heart had to strain against an elevated TPR. There's a spike in pressure. When they've done similar studies like this now in bodybuilders, they have measured pressures when someone was doing the leg press machine as high as 480 over 350 during professional bodybuilders doing a leg press machine. 480 over 350 millimeters of mercury. So we cannot discount what that would do to the heart over time. The first thing to know is that resistance training has been used in patients with congestive heart failure and coronary artery disease without any adverse effects. So even though we see a spike in pressure during the bouts of activity, resistance training can safely be used with these patients without adverse effects. So let's look at what happens in the body during these effects. The first one we already talked about, in that we would expect cardiac hypertrophy to happen, and that is because of those intermittent elevations in blood pressure during activity. So as a response to the left ventricular overload, it stimulates cardiac hypertrophy. And while both aerobic and resistance training can increase the formation of sarcomeres in parallel, you get the most concentric hypertrophy with resistance training because of the acute bouts of increased pressure and ventricular overload without some of those changes in volume that we see with aerobic training, like the increased blood volume stretching out the ventricle. So as we mentioned when we were talking about cardiac hypertrophy, in response to resistance training, you would expect increased cardiomyocyte cell width because the sarcomeres are being added in parallel, as opposed to eccentric hypertrophy, where you see an increase in cardiomyocyte length, because we're adding them on in series in eccentric hypertrophy and adding them in parallel in concentric. Because of this, the thickness of the ventricular wall will increase because of the increased thickness of the myocyte. And even though the walls get thicker, you don't see a corresponding reduction in ventricular volume. So the size of the ventricle, the volume here, is the same as the volume before the training, which is very different than pathological eccentric hypertrophy, where the wall moves in and closes down the ventricular space. So with physiological cardiac hypertrophy, there's no reduction in end diastolic volume. Now, there is some data to support, thus the use of the word can instead of like it does, that resistance training can lower blood pressure in normotensive and hypertensive individuals. Now, the data that supports that is not rock solid, so I'm going to put a big kind of asterisk by that. But this is an important thing that continues to be researched, and the possibility that strength training might lower blood pressure is extremely exciting. Resistance training has a big impact on vascular health, and we see this effect because of the large changes in flow that go through our blood vessels. When it's being completely occluded during the contraction, there's a lack of flow and a buildup of all these metabolites. And then when the contraction releases, there's this big vasodilator response that stimulates the endothelial cells. And when there's a high amount of flow going by endothelial cells, it releases nitric oxide. You guys remember nitric oxide in our pathophys story? We talked about those endothelial cells, and they release that really important gas that says no, no, no to any of the cells sticking to the walls. That no, no, no was nitric oxide. So the process by which resistance training kind of manipulates and alters flow through a vessel actually stimulates the release of nitric oxide, and it improves what's called the bioavailability of nitric oxide. So you're better at making it, and you don't break it down as quickly. So nitric oxide reacts with oxidants. If there's a high degree of oxidative stress in a cellular body, it basically like gobbles up all the nitric oxide. So because we have improved antioxidant capabilities and we have a better ability to make nitric oxide gets to hang around longer. And as a reminder, the loss of nitric oxide is the first step of atherosclerosis. Right, in our pathophys class, and this drawing was somewhat like this, we had all these factors like high glucose or high LDL or high pressure from hypertension. All these things damaged endothelial cells and ultimately reduced nitric oxide in the pathological state. And when nitric oxide isn't there, the vessel becomes very vulnerable to atherosclerosis. So this is one of the primary mechanisms whereby resistance training can offer a protection to blood vessels against the formation of atherosclerosis. So this statement has been backed up by a number of sources, and it's really important to know that everything you know about resistance training, that you can increase muscular strength, you can increase muscular endurance, you can improve a patient's functional capacity and independence and quality of life, all while you reduce disability. And this is possible in people who have cardiovascular disease and people who don't. So all of the benefits that we've talked about over the course of the semester of strength training and exercise prescription have the same ability to benefit someone with cardiovascular disease, and in some ways have more specific benefits to someone with cardiovascular disease. The final piece of cardiac rehab is phase 3. So you typically have around 12 weeks in phase 2, depending on the patient and how they're doing. And then the ultimate goal is to transition them into a maintenance program. So a lot of patients are encouraged to go to community centers to continue exercise, or get a Y membership, or some other place where they can keep up their exercise goals. In order to move to phase 3, you have to at least have a 5 MET functional capacity. That's that ceiling where you need, basically for most ADL performances, you have to have at least a 5 MET functional capacity. They have to have clinically stable angina. So remember, stable versus unstable. Stable angina is clinical evidence of a mismatch between oxygen supply and demand in the heart, meaning the heart has exceeded the ability to deliver oxygen to it. Stable angina is hallmarked by it goes away with rest. If you decrease the work demand of the heart, you should be able to restore balance in that oxygen delivery. Stable angina should respond to nitric oxide or nitroglycerin. When they take their nitroglycerin, it should relieve the symptoms of angina. Stable angina should be predictable. Patients should know, if let's say they get angina, if they do that third flight of stairs, if there's a Schrader complex and they have the option of elevator or stairs, and it's 3 flights of stairs. They're like, if I go more than 2 flights, I start to get chest pain. That's stable angina. It's a known stimulus. It's a known myocardial workload that induces it. And a lot of our cardiovascular patients do have stable angina. They have had medical interventions that have improved things, but there's still going to be a ceiling to what their heart can tolerate, and they have to be able to live within that ceiling and know. That's why they get really good at self-monitoring and then medically controlled arrhythmias. So phase 3, I think maybe in the books it's supposed to last 6 to 12 months, but technically it's for the rest of their life that they should be keeping this healthy lifestyle. All right. Thank you for your attention. I hope you enjoyed this information about how exercise changes us over time. Have a great day.